Welcome back to Mysteries of Health Under a Lens. If you are new here, I am a doctor currently completing my residency in pathology, and my goal is to help you understand what is happening at the microscopic level. Just a quick disclaimer before we begin. This video is a professional medical review intended strictly for residency preparation, lab analysis, and objective diagnostic education. I will be focusing purely on the high yield biopsy findings and underlying disease mechanisms rather than clinical management or treatment protocols. Please do not use this information as a replacement for medical advice. Today, we are going to break down maturation patterns in amyloid. Today, we are going to break down maturation patterns in myeloid lineage. Alright, then, let's get started.
So, good evening, everyone. We are going to discuss today the maturation patterns of especially the myeloid lineage. And this is predominantly focused on the flow cytometry, use of flow cytometry. The study of maturation pattern means the antigen expression pattern with respect to different stages of myeloid cells. And in myeloid lineage, we will include granulocytes, monocytes, and erythroid series, and also a couple of slides on eosinophil, basophils, and dendritic cells. So there are two presentations. First, I'm going to discuss what are the normal maturation pattern with the different lineages using different markers. And then the second presentation will be focused on the small presentation, basically focus on three cases. We'll see the different the cases with history, morphology, and immunophenotypic pattern and how they are different from the normal. Okay, so please feel free to stop me and ask any question in the middle of the presentation. Now, when we look at the maturation pattern, we all are aware of morphological pattern, right? We know that the granulocyte series matures from the myeloblasts to promyelocyte, right? Myeloblast from myeloblast to promyelocyte, we know that, and from promyelocyte to myelocyte, myelocyte to metamyelocyte, and finally we have neutrophil. So this is morphological maturation pattern. Now, this maturation pattern can be also studied by the alternate ways. Morphologically, when we look at the morphology, we look at nucleus, cytoplasm, color of nucleus, then presence of nucleoli, chromatin, whether it is fine chromatin, condensed chromatin, right? Presence of granules, right? Shape of nucleus, amount of cytoplasm. So these are the different things we look at when we look at the maturation pattern under microscope with Romanesque stains like Leishmanov prints or Wright stain. Now, there are alternate way to look at this maturation pattern, and that alternate way is to look at the protein expression, because at different stages of different cells, the variety of proteins are expressed on the surface as well as inside the cell, and based on the level of expression, the presence or absence of protein, the level of presence of protein, right, that is density of, we can also differentiate different stages of this lineage. And these stages of this protein expression is basically tightly regulated by the gene expression pattern. We know the central dogma of cells is that we know that we have DNA which give the RNA, and then from RNA we develop mRNA, and from mRNA we get protein, and these proteins are expressed. And because these are protein, the expression is tightly controlled by the gene expression. This protein expression is constant in all human or at all ages of the human being, from the child to the old age, and in any race or on the earth. Okay, so that means if normal maturation in normal cells, normal protein expression will be tightly regulated by this. But if there is any neoplasm where there is a genetic change, that genetic change will result into the abnormal protein formation, which can result into the absence of protein, increased expression of protein, decreased expression of protein, or altered expression of protein, which result into the deviation from the normal. And this deviation, this abnormal expression of protein can be used to study the dysbiosis in the given cells. That is dysbiosis, like when we say morphological, there is a dysbiosis, similarly the protein-based dysbiosis. Now this protein can be studied by the different methods. One is the cytochemistry, we look at the cytochemistry. Then immunohistochemistry, or histopathology, we look at the protein expression by using it. Then we have flow cytometry, and then even mass spectrometry. Mass spectrometry can also be used to study the protein. Then other research, other methods which can be used for in the research in Western blot, protein electrophoresis, all these there. So today's section will be focusing on flow cytometry, because flow cytometry allows you to study multiple proteins in the same cell, because flow cytometry allows you to study like 8 to 16 to 32 proteins on a single cell. Now, advanced flow cytometer allows to do more than 30, but the routine clinical flow cytometer nowadays use at minimum 8 color and up to 12 or 13 color. Some laboratories even 16 color. 16 colors means we can study 16 different proteins on the same cell at the same time simultaneously, and then we can correlate the expression pattern by combining the two or more than two proteins to look at if there is any relation between this protein expression and at different stages of maturation of different cell lineages. Now, when I say protein expression, I'm showing you how this protein expression and what you mean by synchronous protein expression. When I say synchronous means the expression of one protein in relation with the other. So that when we are considering two proteins together, what is their expression pattern and how it changes in relation with each other. That is synchronous expression pattern. So there is synchrony between the two protein expressions. And I'm going to show you with this cartoon what do you mean by the synchronous protein expression. Now I'm going to show you an example. This is a cartoon of immature, most immature is blast stage. Then the later stage, that is the promyelocyte or myelocyte stage, metamyelocytes and neutrophil stage. And we are going to take an example of three proteins. Let's say protein A, protein B, and protein C, and how the protein expression changes when the cells mature. Now, let's say this is a so this is a protein. Okay. Now we have three types of protein here. One protein, if you look at protein A, at the earliest stage of maturation, we can see that this protein A is densely expressed. That means the intensity is high, density is high. And there is another protein B, which is there, but it is small in intensity. Right? Okay. So, but the protein C is not there. Now, if you go to the next stage of this, let's say myelocyte, where also you have both protein, but if you look at the density of the protein A is reduced and protein B is increased, but still we do not have protein C. Now, when you come to the next stage, that is, let's say, metamyelocyte stage, now here you can see the density of protein B is increased, protein A is reduced, and now at this stage the protein C starts appearing, right? And we have one stage, that is the last stage possibly in this cartoon, that we do not have protein A at all, but we have equal distribution of protein A, B, and C. So this is the maturation pattern. So if you look at its now let's remove the cells. So you have only proteins now, right? Amount of proteins at different stages. So based on the amount of protein, because these are tightly regulated by gene expression and does not changes from individual to individual, we know that if this amount of protein is there, protein A is there, and this amount of protein B is the earliest stage. If this amount, the equal distribution of protein A and B is there, then it is next stage. If we have all three, but only the protein B is high and the other two proteins small in amount, that means that is typical stage, let's say metamyelocyte stage. And if we have only protein B and C and we do not have protein A, that means that's terminal stage. So based on the density of protein, we can imagine and we can correlate the morphological staging. Now, not necessarily the morphological stage exactly match with the protein based thinking. There can be little differences, little variation. But uh, by and large, we can still categorize different subset, or in fact, we can even categorize the minor subset based on the protein expression. Now we can differentiate between the three stages of blast, two stages of myelocyte, metamyelocyte. We can even look into the deeper stages, which morphologically it is difficult to differentiate. But because we can use a lot of proteins, 8 to 10 proteins simultaneously, we can differentiate these cells based on the protein expression. And if you look at the stages here, if you look at the first stage, this is how the protein is changing. The protein expression is changing. So protein A is reducing in the intensity as we go from earlier stage to the later stage. The same way, when we look at the protein B, it is increasing in the intensity, and protein C also increasing, but at later stage. So based on this level of expression, we can differentiate. And because we know the one relation of the one protein to another protein, here this is the highest, this is the lowest, and as the cells mature, it becomes another. And when the cell terminal becomes bigger, so based on this, we can establish a relationship between the protein expression level at different stages, and we call it pattern. So because there is a regulated expression level, and there is a relation between the two proteins or three proteins. Combining this relation expression level of this protein, we if because these are highly reproducible, we call them patterns, and based on these patterns we can identify different stages of the cell's maturation, and that's why we call it maturation pattern based on the antigen expression or the protein expression. So that comes the maturation patterns in myeloid cells. So myeloid lineage, today we are going to study myeloid lineage. In Thursday, Dr. Gaurav will take the lymphoid lineage. So what we are looking at, and the benefit of this pattern is that we are looking at single cell at a time. So we are collecting all the cells together. So we study millions of cells or lakhs of cells. But at the same time, the protein expression on single cell can be studied by using this technique, that is flow cytometry. Now, how do you we call something normal, because in all normal individual, when you study this cell, this pattern, the antigen patterns is consistent and reproducible. Now when you call abnormal or neoplastic or clonal pattern, when you have an antigen which is either increase in the intensity or decrease in the intensity of antigen expression, there is asynchrony between two proteins, or there is aberrant antigen expression. Aberrant antigen expression means the antigen which is not supposed to be present, but it is present. That is aberrant. And homogeneous expression. So some antigen also there is a variable and or heterogeneous antigen expression, but it loses its heterogeneity and becomes homogeneous expression. That also called as an abnormal norm. I'll show you with some pictures which are modified using and kind of funny. So here you can also look at. So we know that a dog has 4 legs, but instead of you have 16 legs, then it becomes increased, something which is normal, increased than the normal, right? As shown in this cute dog picture, that there is increase, which is abnormal. Now, loss of antigen, something which should be there, but it is lost, right? So that can be, so this picture indicates loss of head basically. So loss of antigen is also considered abnormal. Then asynchronous. Asynchronous means the antigen expression which is supposed to be at particular stage, it's not there, but it is expressed at its unusual place, unusual stage of maturation. That is called as asynchronous antigen expression with respect to something else. For example, you have eyes and mouth on the face, but not on the food. So food and eyes, it's asynchronous, right? Just it's a bold example. And lineage aberrant expression means some antigen which is not supposed to be. For example, T cell antigen like CD7 or CD19, which is B cell antigen, is expressed in myeloid lineage, which is also considered aberrant expression. Or CD56, which is NK cell antigen, is expressed on the myeloid cell. So here you can in this picture like dog face on a pigeon. So the completely unexpected antigen expression from one lineage to another lineage is also considered abnormal. Okay, so what we are going to consider here in today's talk is the stem cell. We look at stem cell means blast, specifically myeloid blast, not lymphoid blast. Then we'll study granulocytic lineage, monocytic lineage, erythroid, and briefly eosinophil, basophil, and mast. Now, since we have students who have not introduced or have seen flow cytometer and flow cytometry technique, and the today's talk is focused on flow cytometry. I will take you through the couple of slides of basics of flow cytometry to have a general understanding, so that we are on same page at different level, but some page, and you have some understanding. I'm going to show these are the flow cytometer. This is how flow cytometer looks. If you are not seeing flow cytometer, you can Google and see the different images. There are multiple videos and workshop talks there in the video. So these are different flow cytometers. This is from the different company. So you can there are four major companies which supply flow cytometer. One is Becton Dickinson, that is BD. Now it's called Waters. Then we have Beckman Coulter. Then also the Thermo Fisher, Sysmex, and then there are new companies like Cytec who also and Sony which also provide advanced flow cytometry. Okay, now how do we study the cells in flow cytometry, right? Because I've already mentioned we study single cell. So we have to make a single cell suspension, usually in bone marrow, in peripheral blood. In fact, in FNA from the tissue, you can take tissue and cut the tissue and make a single cell suspension. Body fluids like CSF, pleural effusion, ascitic fluids, anything, any cells which can be analyzed in single cell suspension can be used for flow cytometric analysis. Now, how do we process? So usually the common samples which studied for flow cytometry is peripheral blood or bone marrow. And in bone marrow, we know that peripheral blood bone marrow, we have WBCs as well as RBCs. You can see that we can have RBC and WBC. Now, if our focus is the WBC, then what we know that the RBC is in multiple times present in the sample, so they will hide or they will interfere with our WBC analysis. So we want to get rid of RBC and RBCs if we want to focus on WBC. So what we do is lyse the RBC. We use ammonium chloride solution for that. So what we do, we take sample, we add ammonium chloride and ammonium chloride specifically lyse RBC. So we get rid of RBC and then we take this WBC. And what we do, we add antibodies which have frochrome attached to them. So you can see there are antibodies, there are different frochromes attached to them against specific antigens. So we study different types of proteins which have antigen on them. And these antigens are studied by using different antibodies which have frochromes attached to them, so that this can be detected by using flow cytometry. And what we do, we take these WBCs after lysis of RBC, we add all antibodies, we incubate them in the dark so that this antibody bind to the antigens on the cell's surface or inside the cell of different WBC. And then once we have this antibody attached cells, then we run through the flow cytometry. So how the flow cytometry detect them? So then we follow two principles. One principle is the measurement of physical property of a cell. What are the physical properties of cell which we want to monitor? Anybody can answer? You know which physical properties we usually look at when we look at the cell? Anybody from the student can answer this? Anyone? Which physical property, right? What are the physical properties of a cell when we look at the surface smear or bone marrow?
Sir, size of the cell, also the complexity, like granules are present that gives the complexity, that is granularity.
Perfect, absolutely perfect. So we look at let's say when we look at the lymphocyte or blast or granulocyte, metamyelocyte, neutrophil. What we look at the size of the cell. This is small size or large cell. Like monocyte, we look at the size of the cell. Then we look at the presence of granules If they are small size, no granules, we know that they are lymphocytes. If they are large cell, they have fine granules or they have granules with irregular nucleus, we know that those are myeloid, right? So based on the similar can be done by flow cytometer. So how to do that? So in flow cytometer, we have something called as there is optics. So where we have a laser and a system where a single cell is thrown in front of the laser. Each cell comes in front of laser as a single line. Okay, so we will not go into the mechanism of flow cytometer, but principally we have a mechanism in flow cytometer where a single cell at a time come in front of laser. Now the laser light hit the cell at multiple part. Right here you can see the yellow light basically is represented the laser light, and you can say when a single cell come in front of laser, the laser light hit the cell at the surface, right? And when it hits the right sample, it get deflected or diverted based on the size of cell in a forward direction, right? If the cell is small, the diversion is less. If the cell is large, the diversion is high. So based on the size of the cell, this diversion of the light which is going in a forward direction changes. That means if the diversion is less, the size of cell is small. If diversion of this forward light scatter is high, that means the cell is large. So based on the diversion, that is called as a forward scatter. The diversion is defined as a scatter. So if forward light scatter is high, the cell is large. If the forward light scatter is less or small, the size of cell is small. So based on that, we know the size of cell. The same principle is also used in your cell counters also, laser-based cell counter. Okay, so that's how we differentiate small and large cell based on the forward light scatter. Now, at the same time, some of the rays of this laser also go inside the cell and hit the granules or the cell organelles present inside the cell, and they are also reflected, diverted in the different direction. So this light which will be scattered by the granules will be scattered all over in the side of the cell in all 360 direction angle in the side of the cell, and this is called as a side scatter. And we know that this side scatter is not coming because of the cell granules or cell organelle present inside the cell. Now in cell counter, in flow cytometer, this side scatter is collected predominantly from the right side of the cell or right angle of the cell. It's called as a right angle scatter or the side scatter because we are collecting this scatter of light from the side of the cell. So called as side scatter. If the side scatter is high, then that means the cells have a lot of granules or cell organelle in it. The cell is complex. If the side scatter is low, that means cell is not complex, it does not have granules, or the cell has very scanty amount of cytoplasm and very few minimum amount of cell organelle. For example, in lymphocyte, we know the cytoplasm is scanty and there are no granules except large granular lymphocytes. So it will have minimum side scatter. But we know that neutrophils have a lot of granules in it, abundant cytoplasm. So we will have a lot of high side scatter because those cells will scatter the laser light at the highest amount. So this is a principle. How do you differentiate the size and the cell complexity using this principle? Okay, this is the detection of physical characteristics. Now we have to identify different proteins which is present on the cells on the side of the cell. So how do we do that? We have already seen that we put antibodies which are attached to the flow cone, which will bind to the different protein based on their antigenic property. So we take these cells. This is a cartoon. This is a cell. We have different proteins here, and these proteins will bind to the antibodies, and these antibodies have different flow cones attached to them. Right? Why different flow cones? Because if we use the same flow cone, the flow cytometer cannot differentiate in different antibodies and different antigens. So that's why we use different flow. I have shown you here 4 we can use 8 fluorochromes, which is called the 8-color instrument. We can use 12 fluorochromes, so that these 12 antibodies will bind to the 12 proteins, and because we are using 12 different fluorochromes, it can differentiate 12 different proteins on the same cell. Now, when we have such cell come in front of laser, and when laser light hits this fluorochrome, these the fluorochromes get excited and they emit the different fluorochromes light. Based on their wavelength, the flow cytometry is designed in such a way that it separates each fluorochrome light from each other, and it measures its intensity, which we can identify using the different dot plots. This is called as dot plots. And we know that, okay, this P fluorochrome and these are APC fluorochrome can be differentiated, and because these fluorochromes are attached to the particular antigen antibody complexes, we know that this present is there, this antigen is present on the cell. For example, if the cell has CD7 present on it, the protein CD7, which was attached to the fluorochrome P, we have detected it here. So we know that means we know that there is a P positive CD7 present on the cell. That means those are T cell or NK cell. We know that CD4 is positive because we have seen the signal from the APC fluorochrome, and we know the APC was attached to CD4 antibody, which attached to the cell. That means these are CD4 positive cells, like CD4 positive T cells or monocytes. Okay, this is how basically we identify based on the shape, complexity and size of the cell, and different proteins. Based on the different proteins, we know which type of cell it is. Okay. Okay. So, do anybody have any question or any query till now?
No queries in chat box, sir.
Okay. Okay. And the students which are in the panel, if they want to ask any question on the basics of flow cytometry, I can answer now. Okay. Great. Now, if you look at the hematopoietic system, we know that how it grows.
Sir, there is, sorry, sir, there is one question. Why do we do gating?
Okay, gating will come to that. Basically, when we study the cells, here you can see if you take a bone marrow or peripheral blood, we see all mixture of all these cells, right? There will be myeloid cells, there will be lymphoid cells, there will be mature lymphocytes also, there will be immature granulocytes also. So if we want to study, and if in the sample, at the same time we'll have all this mixture of all these cells. You will take bone marrow, we'll have lymphoid cell, erythroid cell, granulocytes, blast, everything will be together. Now, if you want to study only a specific population, then what? Right? Then so to study a specific population, we have to use a specific marker to get them. For example, it's a lymphocyte T. If we want to study T lymphocyte, then based on the T lymphocyte, so we identify T lymphocyte using CD3 expression. So what we'll do, we take CD3 positive cell, and because we do not want to see other cells, and we just want to focus on T cell, we use an electronic or digital electronic window, where it will allow you to just study the specific population, and that electronic window or digital window is called as a gating. Okay. So basically, gating allows you to see only a specific population based on the specific marker or combination of specific marker, which will disappear the other cells from your dot plot, from your screen, from your analysis plot, so that you can focus on specific cells, and that is called the gating. It's like a window. When you want to look at window outside, window will allow you to see only the population out of the city or the outside world, which is possible through that window, which will not allow the other rest of the world, even it is there. The same way here, the gating will allow you to focus on particular population based on the marker or combination of marker, where you identify and put the gate, and then you study on this population. I will show you with example. Okay. Now,
next query is, do these probes go inside the cell also?
Sorry, what?
Do these probes go inside the cell also?
Inside, sorry, I'm not clear.
Inside the cell also.
Yeah. So you can use the marker protein present inside the cell also. Yeah, of course. So
That's also.
yeah. So the marker can be, the protein can be present on the surface or inside the cell. So we have, so for example, MPO. We know that MPO is present in the granules inside the cell. So we study the MPO, and based on the MPO, we know these are myeloids. The same way we have certain markers like let's say TDT, which is present in the nucleus. So we identify these are immature the lymphoid blast because the TDT is positive. So we can study and we can gate also based on that. Okay. So we know that myeloid series, usually we have these four major lineages. We have myeloid, granulocytic. Okay, so myeloid include everything basically. Myeloid is the bottom, but to be specific, we said granulocytic series where we have predominantly monocytic series and then erythroid series. Okay, megakaryocyte series it usually is difficult to study normally because there are very few precursors of myeloid megakaryocyte lineage, and there are very few megakaryocyte in the cell. So it's difficult by flow cytometry, but if they increase, for example, there is a megakaryocytic leukemia, then you can study. Okay, and lymphoid, Dr. Gaurav is going to cover. So we are going to focus on this part. Now, to focus on this part, we have variety of markers or antibodies we use. And what are these? So I am just here. We have some markers which, with the help of which we identify immature cells or blasts. So those include CD34, which is stem cell marker, and we identify blasts with there. In addition to that, we have CD117 and CD133, which also we identify these cells. And there are certain markers shows co-expression on this. So we use these markers to identify precursors or blasts. Now, for myeloid lineage, we use markers such as CD13, CD33, CD117. These are the common myeloid lineage markers. Common means they are available in almost all laboratories we use for cytometry. In addition to that, the other common markers are CD11B and CD50. Okay, so these are myeloid markers 11B, 13, 15, 33, and 117. Then monocyte lineage is also part of myeloid lineage. Hence, they also express these markers at different intensity. Means they also express 13, 33, 15, 11B, but with different intensity. So granulocyte will have different intensity, monocyte will have different. In addition to this, we also study this monocytic lineage by using CD36, CD64, CD14, CD16, the CD163, 116. There are other markers which can be used. Now, common monocytic markers are CD64, CD14, CD13, 36, and 33. And HLA-DR, which is also MSC type 2 molecule, which is present in monocytes because monocytes also work as an antigen presenting cell. Then for erythroid lineage, we use, in addition, we use CD36. CD36 is common here, but the 13 and 33 are usually absent. These myeloid markers are usually absent in erythroid cells, but they express other markers like CD71, strong expression of CD71. We have CD105, glycophorin A, there is 43, 49D. These are the markers which are specifically used to focus on erythroid lineage. That is NRBCs. For megakaryocyte, we have 36, and we have specific proteins which are used in platelet antigen basically. So these are CD41, 42B, 61, 62. For basophils, again, basophil is a part of myeloid lineage, so they express some myeloid markers like LNB 13, CD203C, and there is a specific strong expression of specific marker CD123. And these basophils are typically shows negative expression of HLA-DR. So HLA-DR is absent on basophil. The same way, even the mast cell express the same markers, but mast cell are specifically shows negative expression of 11B. The rest of markers may be positive, but the 11B is negative, and the other typically they have 117 strong expression of 117. which basophils shows weak expression or negative expression of 1-1 cell. So there is a difference between basophil and mast cell. The 11B is present in basophil and absent in mast cell, and 117 strong expression is present in mast cell and usually absent in basophil. Both shows the negative expression of HLA-DR. Here, basophil shows strong expression of 123. Mast cell usually dim to negative expression of or weak expression or negative expression of 120. So that's the. Then comes plasmacytoid dendritic cells, which are the common antigen presenting cells in our body, especially in blood and bone marrow. They have typically they have strong expression of 123 and HLA-DR expression, but we also have additional markers like say CD303 and 304, which is also expressed, which is also called BDCA4, 2 and 4. Then for B cell, we know that there are B cell marker like 20, 19, the other markers which will be explained in Dr. Gaura's talk. Then we have T cell marker like CD3, 4, 8, 7, 5. All single digit markers are usually for T cell, like 5, 6, 7, 8, like that. And for NK cell, they have specific marker like 16, 56, and there are specific NK cell markers. So these are the different markers, antigen, which a common flow cytometry lab have to identify the different cells and to study these different cells. Now, out of them, as we know, there is lineage specific marker. The MPO is for myeloid lineage. For monocytic lineage, we use 2 or more than 2 cell markers. Two markers like CD14, 64, 11C, 36. For T cell, we know there is a cytoplasmic CD3 or surface CD3 specific marker. And for B cell lineage, we either use a combination of 2-3 markers. Either there should be strong CD19 expression and 2 variable in addition to that, either 1 strong out of 79A, 22 or 10. Or if we have weak CD79 and CD19, then the two of these 3 markers should be strong. Okay, so this is about lineage. Now we are going to go for individual compartment and their maturation pattern. Now remember, these are the complex maturation pattern, and the MD students or the the person who are not exposed to the day-to-day flow cytometry, it's difficult to understand. So it is fine. Your message is with this is that even inside a stem cell compartment or a blast compartment also, if you study protein in details, we can see the different maturation pattern with the combination of multiple proteins, which also gives a pattern which we use to differentiate normal blast from the abnormal blast. Okay, these compartments or this maturation pattern is predominantly used to study the abnormal blast or clonal blast and to differentiate from the normal blast. Okay. So if you look at stem cell undergo maturation at different stages.
We have some doubts in chat box. Sorry to interrupt you, sir. Shall we take after the session? We have some doubts in chat box. Shall we take after the session?
Oh, you can take now if you have a question. No.
First is upon having pores and large granules in basophils, why do they have low site scatter?
Okay, so yes, that's a very good question actually. So granules, the basophils granules, if you look at the basophil or mast cell granules, they are typically metachromic granules. Okay, and the light scatter is based on the property that these granules reflect the light, right? So the light will come, hit the granules, and the granule will reflect the light, and that's how we get the scatter. Now imagine if you have a granule, such a granule with such color which absorbs the light, right? So if a granule absorbs the light, it will not reflect only, and since it doesn't reflect, there will not be scatter. So basophil or the mast cell granules are the metachromic granules. They have property to absorb the light. So they do not reflect the light, or even if the reflection is minimum, which will not give you higher scatter, and that is the reason there is no scatter, there is a low scatter in the basophilic or mast cell granule. Sometimes mast cell have complexity, so they may have little higher scatter as compared to the basophil.
Sir.
Okay.
The other question is concept of events and how do we decide number of events?
Sorry, so you have to repeat because your audio is not very clear. Yeah.
Okay, so what is concept of event and how do we decide number of events?
Okay, events. So events means the number of cell you want to study. So in flow cytometry language, the cell is called the event because one cell is going through the laser. So it's a continuous process. It's like it's a physical process. So we call it when a cell come in from laser and laser interrupt. It's an event, like right. So that's why it is all anything which you note in flow cytometry, it's called as the event. Because so each cell means each event which is noted by flow cytometer or even the other instrument like cell counter. Okay. Now, so
Prashant, can I come in? Can I come in here?
Yeah, please, Vanessa.
There are two things. One is the basophil granule. One, as Prashant has explained. The other thing is basophils can degranulate fast, as well as basophil granules can be lost during processing as it happens in peripheral smear due to exposure to water. So both these things will reduce the basophil granularity in addition to the explanation which Prashant has given. The other thing, event, is we call it an event because any particle is considered an event. So all events are not cell, but cells are events. So that is the way it is. Debris can also be event. A cell fragment can also be event. So to differentiate, since we don't know to use a very specific term, that is all events are not cells, so we call it as an event. But when we try to get out all the debris and events which are non-cell. So that is the way we get at that time. After that, it becomes a cell.
Yeah. So the question was, how do you decide the number of events? So basically, what level of sensitivity we want to study, that depends on. So that on that basis, if you want to study 10,000 cells, then you acquire accordingly the number of events. Of course, you have to disregard the number of debris and platelets which are there. So it's little technical question based on the gating system and viability. You have to identify. So when we'll discuss the plot, probably that time I will tell you the number of events. But to decide the number of events is basically based on the decision is based on the number of cells you want to study. So if you want to study, let's say 1 lakh cells, so you have to prepare the cell solution and cell suspension in that way, so that you will have at least 1 lakh viable cells after excluding debris and the other junk like platelets, clumps or anything like that. So that's how you have to design an assay. So it depends on the sensitivity of assay. If you want to study 1 lakh cells or you want to study 1 million cells, based on that you decide how number of events you want to acquire and study. Is there any additional question?
No, sir, only that much. Thank you, sir.
Okay. Okay. So coming to the stem cell compartment. Now, stem cell compartment, you have, you have hematopoietic stem cell, which usually the long term, the short term. So this self renewal happens in long term, hematopoietic stem cell, and hematopoietic stem cell then divide and become multipotent progenitors. Then they become, common myeloid progenitors, which include progenitor for granulocytic monocytic precursor and megakaryocyte erythroid precursor. And then they becomes, erythroid becomes divided into erythroid cell, megakaryocyte becomes megakaryocytes, granulocytic myeloid precursor becomes monocytic precursor becomes monocyte, granulocytic, some of the cells will become neutrophil, some will basophil, some will, eosinophil. And from this multipotent progenitor, some cells will becomes common lymphoid precursor, and from common lymphoid precursor we will have B cell, T cell, and NK cell. So this happens. So we'll focus on this part, specifically erythroid and myeloid, monocytic, and eosinophil mast cell, this compartment. and some part will be. So we'll cover from this hematopoietic stem cell, multiple progenitor common, and MEP and GMP part. We'll see based on the antigen expression pattern how they differentiate at different parts, and this we are going to focus to. Okay. Now, when we come to the stem cells, so as I mentioned, we identify all hematopoietic stem cells using CD34. So if we have CD34 positive cell, okay. Now, before that, let me explain how to interpret these dot plots. Okay. Now, this dot plot, you can see this is dot plot. Why this is dot plot? Because we are looking at dots here. Now, each dot is considered as basically when you say event, this is also equivalent to the event. Okay. Each dot is represent event, and by and large, majority of cells events are considered as a cell. So these are all dots, and these dots represent each dot represent each cell. Okay. Now here, if you look at this dot plot, you can see there is a scale. There is a y-axis scale and there is the x-axis. Now this scale starts with 0 and it moves towards on the logical basis towards 10⁻⁴, 10⁻², 10⁻³ You can here you can see. Okay. So cells, the dots which are close to 0 are considered negative for the antigen which is labeled on this scale. Right here you can see the CD38 is the antigen or antibody which is labeled on x-axis and CD90 on y-axis. That means the cells which are present close to the 0, that is left lower quadrant of this dot plot, these are negative for both for CD38 and for CD90. But as the cells becomes move towards away from the 0, towards this end of the scale, they become this antigen expression start the positive expression, and we call them positive. For example, this red or the pink dots here are away from the 0 and towards the positive part of this end of the scale. We call them positive for this antigen. So these red cells are positive for CD38 and these blue cells are positive for CD90. Okay. The same way here, these cells, you can see that this population is negative. These cells are negative for this 45 RA and 33. This population which is away from the 0, this cluster of dots towards the 10⁻⁴, this is positive for 45 RA, and this population which you can see here, which is away from this 33 positive. Now this population, if you consider, they are positive on the y-axis as well as x-axis. That these cells are positive for both markers, so the 33 as well as 45 RA. So there is this population simultaneously positive for RA and 33. Here you can see they are this cyan blue positive population is just positive for 33 because it is positive towards 45, but it is close to the 0 for 33. So this population is negative for 33 and positive for 45. This brown population is close to the 0 for both axes, so that means this negative for both. This orange or red population, you can see the part of it, this part is positive for 33 but for negative for 45 RA because it is close to 0 on y-axis. But this population, which is bluish population or purple bluish population, it shows positive for 45 RA as well as 33. That means there is a co-expression of both markers. Okay. Now, if we take all 34 positive population and we study this 19, 38, 45 RA and 33, that means we are studying combination of 4 antigen expression on the same population, then can we divide this population into different parts? Okay, so we have taken all 34 positive population and just look at the two protein expression 90 and 38. So you can see there is a population which is positive for 90 and negative for 38. These are the earliest hematopoietic stem cell population. The population which is 34 positive, 90 positive but 38 negative. Okay. Now a population of 34 positive cells, which is CD90 also negative and 38 is negative, represented by green color, green dots, is basically multipotent progenitors. Okay. Now there is a population which is CD90 negative because close to 0 here, but 38 positive, and this population is called as a either common progenitor, so common myeloid or lymphoid progenitor. Okay, so these are the progenitor which is there, common myeloid lymphoid progenitor. So here you can see the common myeloid lymphoid progenitor which has 30, which is 38 positive, 34 positive, but 90 is negative. Okay. Now, if you take this population that is common myeloid lymphoid progenitor and study the expression of CD45RA and 33, you will see there it forms a multiple cluster. There is one cluster here, one cluster here, one cluster here, one cluster here. So almost almost there are 4-5 clusters. If you put them, give them color, we have a cluster which is 45 RA positive but 33 negative. This is common lymphoid precursor, progenitor. Then we have a cluster which is 33 positive but 45 partly positive and partly negative. That is granulocytic, monocytic precursor, progenitor. We have 33 weak as compared to this population, but 45 RA nicely positive. It is plasmacytoid dendritic cell precursor. And we have a population which is negative for both CD45 RA and 33 here. That is erythroid megakaryocytic precursor or megakaryocyte progenitor. From this population, erythroid and megakaryocytes will come. From this population, myeloid B cell and T cell will come. From this population, we have dendritic cells, and from this population, we'll have monocytes and granulocytes differentiating from this population. Remember, these are all CD34 positive progenitor based on their antigen expression pattern of 38, 45, and R33. We have divided into multiple subsets. Okay. Now, remember this color to track the different antigen expression pattern. Now, this is little complex, and you need a lot of experience to understand. And repeatedly, you have to look at these dot plots for months or years together to understand, but you have to focus and see the color to track this population. Here the cyan blue is lymphoid precursor, the dark you can see the brown color is erythroid predominantly because megakaryocyte precursor are very few in number. The red population indicate granulocytic monocytic precursor, and the purple color indicates basically your dendritic cell precursor. Okay. Now, what to confirm what I'm saying, we will use additional multiple markers such as CD22, 117, 123, HLA-DR, and we have already, and 71, and we already have CD33 present in the sample. Remember, these all are CD34 positive cells. Okay. Now, if you look at the cyan blue population here, you clearly see these are 45 RA positive, they are 33 negative, and they are 22 positive. 22 is the B cell marker, which confirm these are B cell precursor, right? B cell progenitor because they are 45 RA positive, they are 33 negative. Now, what about other markers? So you can see other markers like other myeloid antigen, CD117 is also negative there, and HLA-DR positive because HLA-DR again positive in B cell precursor as well as other precursor. Now look at the red population which we see granulocyte. They are 33 positive. Their 71 expression moderate. Now the other terminology which I am going to use moderate or bright and dim or negative. So when I say negative means close to 0. When we say bright means it is the highest of the dot plot on the same axis, and when it is between negative and highest expression, I would consider is moderate or weak expression. Okay. for understanding of this expression level. There is other way to look at it, but for the sake of understanding for today's class, we'll say something which is close to the highest level of the axis. We'll call it bright or strong expression. Close to zero, we'll call it negative, and something in between, we'll call it dim or moderate. Something close to the bright, we'll call it moderate. Something close to zero or negative, we'll call it dim. Okay, so these are the terminology I am going to use. Okay, so you can look here now. You can see there the dendritic cells. As I mentioned, you can see the 123 expression is strongly showing the strong expression of 123. Here, erythroid precursor shows strong expression of 71, right? Even 123 moderate, and HLA-DR is more or less. There are few cells which are gaining CD117 strong expression and loss of HLA-DR. These are mast cell precursor. So this is how you identify and see the maturation pattern. Maturation pattern. Okay. Now this is how we are going to have different antigen expression pattern based on the different markers. So just to show you this, these are the different lineages. We use different markers for monocytic, different markers for granulocytic lineage, different markers for erythroid and megakaryocytic lineage. So now till date, in earlier slide we have looked at the precursor and how they differentiate. Now we are going to look at the mature cell, maturing cells. Okay, so based on these markers, this is another way to look at different maturation pattern. I'm not going into details. I think I'll just skip this part. So to save the time. Now we have, if we use all these combination of different markers, we can look at the maturation pattern. There are different markers we use. This is a 16 color panel where we use different markers to study these cells. Okay. Before going to the maturation pattern, I am going to show you how we use this maturation pattern in day-to-day life clinically and when we call abnormal. So based on this maturation pattern, we know that we put this gate. These are the gates where this normal maturation present inside this. So any population which is going outside this these gates, we call them abnormal. So these are the gates which are formed based on the normal maturation pattern. And we have labeled here the stem cell with blue color and the other cells, the differentiated cells or the committed cells with red color. Okay. So here you can see based on this with 38 and 13, this is how the cells behave. Okay, with this normal maturation pattern. So they have some distinct maturation pattern when we combine these markers together. And if population go outside this gate, we call them abnormal because they are not following this normal maturation pattern. Okay, just to show you an example, here you can see this is normal HLA-DR and 34 expression pattern. But if you have abnormal, so here you can see the HLA-DR is strong, abnormal is strongly expressed. Here, this black population, that means it is abnormal because it is above the normal level of expression, both 34 as well as HLA-DR. Then we have, normally we have CD38 expression like this, right? We have some stem cell and there are some committed cells showing CD38 expression. But if you have all of the cells showing loss of CD38, that also becomes abnormal. Then we know that normally CD13 shows variable expression in stem cell, but loss of 13 is also considered abnormal. Or homogeneous expression of 13, you can see here there is one homogeneous overexpression of 13, which is also considered asynchronous. So there is asynchronous between 13 and 34. 13 and 34 should go like this, but there is loss of 13, that's why it become asynchronous. Or overexpression of 13, that's why it become asynchronous. Or there is just small cluster of 13 and 34, there is no normal maturation pattern, become asynchronous. So that is called as the asynchronous anti-expression pattern. The same way, even 38 and HLA-DR, normally we have this type of pattern, but that pattern is lost here. You can see the down regulation of or loss of HLA-DR. Then we look at 34 and 117. Normally it should go like this. This pattern is there, or 13 and 34 pattern is there. 34 and 33 pattern is there, but that pattern is lost. You can see there is homogeneous expression, right? There is homogeneous expression here. Then there is also aberrant expression of CD7, which is T cell marker. So these are all called as asynchronous aberrant expression. Basically, this is a case of chronic myelomonocytic leukemia, which is showing aberrant blast population. There is another case of chronic myelomonocytic leukemia where you can see there is aberrant expression of 7 on with loss of HLA-DR, or aberrant expression of 7 in the stem cell region of myeloid blast. This is another example you can see here, the overexpression of 36 or abnormal expression of 14, 61, 41 and 61, which is megakaryocyte marker, which can be also seen. So this was a case of primary myelofibrosis, where you can see there is aberrant abnormal blast were present in the primary myelofibrosis case. So based on the antigen expression pattern, we can identify these are not normal blasts, these are abnormal blasts. Again, even in the CML case, we know that chronic myeloid leukemia, we have, this is normal, but there is abnormal overexpression of HLA-DR. You can see there's clearly abnormal overexpression of HLA-DR or overexpression of CD33 expression. So based on the normal or typical antigen expression or asynchronous expression, even for CML case, you can identify the abnormal myeloid blast. Okay, now sometimes only the compartment study is helpful. For example, normal bone marrow, we know there are myeloid blasts as well as their B cell precursor, that is hematobones. But absence of hematobones also indicates aberrant or clonal hematopoiesis in the sample, because normally no matter what is the age of person, there should be always some B cell precursor should be there, and if the B cell precursor are less than 5% typically, then we consider that as a abnormal. So here you can see in both the dot plot there are no CD19 positive B cell precursor, almost absent. So that absence of B cell precursor also considered as abnormality. Then for CML, we know that there are specific stem cells which is defined by using CD26 and 19 expression. So these are called as the leukemic stem cell, or for the CML, which is 26 and 90 co-expressing and 38 heme positive cells. So CD38 heme, 34 bright, 26 and 90 positive black dots are basically stem cell of CML. Another case of polycythemia vera. You can see this polycythemia. Usually polycythemia vera do not show abnormal blast, but sometimes you can get. Here in this case we could find this is normal maturation pattern of 117 and 33, but you can clearly see there is overexpressing cells, the black population, which shows overexpression of 117 as well as 33. Right. There is also overexpression of HLA-DR versus HLA-DR in this population. So you can identify even the myeloproliferative neoplasm or chronic myeloproliferative disease or MDS. We can see this type of abnormality. I just mentioned you have to look at the precursor compartment of hematobones. So in hematobones, if you have hematobones less than 5% in a stem cell compartment, that is 30 positive compartment, it is also called as abnormal. Like in this case, you do not have CD19 positive precursor. Okay, there are a couple of questions for our students, if they can answer. Do you know what is the correct? I just explained what is the correct immunophenotype of hematopoietic stem cell. We have three options: 34 positive, 38 negative, 90 positive, 34 positive, 38 negative, 90 positive, and 34 positive, 38 positive, 90 positive. Do you remember now the students which are in the pack? Earliest hematopoietic stem cell.
Majority have answered option C, sir, in the chat box.
Okay, so any other answer? We have
1A, option A.
yes. So that is correct answer.
More right,
We know that this is the correct answer because all cells are hematopoiesis 34 positive, but the one which is 38 negative and 90 positive are the hematopoietic stem cell, earliest stem cell. The one which are 34 negative is not part of stem cell, and the one which are 38 positive and 34 positive are committed cells. That is myeloid progenitor. That is committed either common myeloid progenitors or common myeloid lymphoid progenitors. Okay. Now this is the utility of studying CD34 hematopoietic stem cell. What is utility? One, the first commonest utility or commonest application of studying CD34 positive hematopoietic stem cell compartment is diagnosis of acute leukemia, where you have more than 20% blast are there and you identify that. Then also we study this stem cell compartment for the something called as a minimal residual disease or measurable residual disease. Especially once you have acute leukemia and when patient receives the treatment, you want to see if the patient responded and all leukemic stem cells disappeared from the patient's marrow or still they are here. Because if you have a small population of these residual cells, this residual stem cells called as a measurable residual disease, which also causes the relapse of the disease, and that's why we want to study that part. Okay, then also that is called the rare event analysis. Then also we study the stem cell compartment for the diagnosis and prognostication of myelodysplastic syndrome. If we want to study CML with accelerated phase, especially the blastic phase, nowadays we do not use the term accelerated phase, we use blastic phase. So if we have myeloid blast more than 20%, and if you have lymphoid blast at any percentage, it's called as a blastic phase. And it can also helpful in some cases, for example, CMML, JMML, even for the CML chronic phase. And stem cell and for stem cell calculation. So to study the number of stem cell present in the specifically hematopoietic stem cell transplant, we use that stem cell enumeration. So these are the common applications to study the stem cell compartment. Right. Just to show you, I have already shown you the example of CMML, polycythemia vera, as well as primary myelofibrosis. But this is an example of MDS where you can see the loss of 13 or overexpression of 13, which I have also shown you the earlier. CMML, this is another example. CMML, we have already seen the expression of CD7 or homogeneous expression of 117. JMML also you see the presence of CD7 expression. Then in CML, I have already mentioned that this is just a repetition of both the plots. Okay, so that was about stem cell compartment. Now coming to the granulocyte compartment, that means the stages other than stem cell. Okay, other than blast. Now we know that stem cell mature from stem cells to the granulocyte series, as well as the next stage comes to promyelocyte stage and other cell. So the next stage from the blast is, we know that is the promyelocyte stage. Now what happens to the promyelocyte when you study CD13 and 117? So you know that this promyelocyte, they are CD117 positive, and this stage, actually at promyelocyte stage, the cells lose CD34 expression. They become CD34 negative and they become strong CD13 positive. Like here you can see they are 13 positive. Promyelocyte stage 13 positive and 117 positive, but negative for CD34. Now when you combine 13 and CD16, it shows a typical maturation pattern. Okay. Now we are going to study that maturation pattern by using CD13 and 16. At the promyelocyte stage level, we have CD13 but no CD16 expression. You can see there is no 16 expression. Next stage is the myelocyte stage. At myelocyte stage, you have no CD. So CD13 is down regulated. That means the loss of CD13. CD13 is lost. Okay, so here we have these olive color cells, which are CD13 and 16 negative. The next stage, we know that the metamyelocyte. At this stage, the cells are negative for 13, but they shows positive expression of 16 at lower intensity. And the terminal stage is the neutrophil, where we have CD13 expression comes back and CD16 expression becomes strong. So by just combining 13 and 16, we can identify promyelocyte, myelocyte, metamyelocyte, and band forms, and then neutrophil. So this population, this antigen expression, if solved, they will closely match with these different stages of maturation with the morphological stages. Okay. So this is how the maturation takes place. Now, based on that, if we use other markers like example 11B and 16 or 13 and 16, we have shown 13 and 16, 11B and 16, it will show this type of maturation pattern. You can see the promyelocytes will be negative for 11B and 16 both. The part of myelocyte and metamyelocyte shows expression of 11B, but they are negative for 16. Metamyelocyte comes positive for 16 and 11B both, and neutrophil shows strong expression on both the markers. So this is the maturation pattern. Using this combination, we know this is the signature maturation pattern. This is the maturation pattern, and the combination of antigen expression at different levels. The study of this is called a study of maturation pattern, because this is typical pattern. The same way, if you combine 11B and 13, you get this type of maturation pattern, right? This is the maturation pattern, and this is the maturation pattern which we'll study. So these are the normal maturation pattern. When you have dysbiotic maturation pattern, when there is a clonal dysplasia, for example in MDS, okay, so this maturation pattern is lost. Here you can see there is no more this maturation, typical maturation pattern which we have seen is lost. Here you can see the typical maturation pattern is lost because there is asynchronous expression of CD13 on the 16 positive granulocytes. There is asynchronous expression. There is loss of, you can see the CD15 strongly expressed, there is loss of CD15. So this type of loss or altered atypical antigen expression pattern is called as a dysbiotic maturation pattern or dysregulated maturation pattern or deviation from normal maturation pattern. Just to show you the example of CMLCP in chronic myeloid leukemia, although with normal on morphology, we do not see much of dysbiosis, right? Other than some hypersegmentation of neutrophil or band form. Usually we don't see. So you can see with 13 and 16, we do not see much of my abnormality, but we clearly see down regulation of CD15 or overexpression of CD56, which is NK cell marker. So this is common altered antigen expression in CML case. Okay. This is another case of CML. You can see there is a normal maturation pattern with respect to 13, LNP, and 16, but there is down regulation of CD15 in this case. Okay, so that was about granulocytic maturation pattern. Now let's go to the monocyte maturation pattern. In monocyte, we know the earliest precursor is monoblast, right? And we are going to study the monocytic maturation pattern by using 14, HLA-DR, 13, and 11B. So we use these 4 markers to study the combination of this expression pattern of monocytic lineage. We have blast which will be 34 positive, but 14 negative, and HLA-DR is also positive. You can see the HLA-DR is also positive here because it's between 0 to 1, and they are 13 positive, but 11B negative. Because usually monocytic blasts are very few in number, you can see the number of events, they are very few. The next stage is again more committed monoblast. More committed, that means HLA-DR is still strongly expressed. Still we do not have 14, we have 11B and the loss of 13. So they are more committed towards the monoblastic monocytic series. Then comes the promonocyte. The promonocyte, we know the morphologically we can identify based on the presence of nucleoli as well as the lacy chromatin, where you can see the fold of the cell. Here you can see the fold and immature cell. And at this promonocytic stage, what happens is again CD13 starts coming. You can see CD13 antigen came and CD14 came. Next stage is the mature monocyte, where you have strong expression of 14, strong expression of 13, and strong expression of LNB, and the typical antigen expression of the HLA-DR. You can see the DR, which was positive, then it becomes little dimmer, and again it becomes positive. So this typical S pattern is there with HLA-DR and 14, and when it comes LNB and 13, typical U pattern comes. So these are the maturation pattern of 14, DR, and 13 and 11. So based on this, we can study these are the normal maturation pattern from the monocytic precursor to terminal mature monocyte. If we combine other markers like CD64, 36, and 14, then you get this type of maturation pattern. We know the 64 is strongly expressed in monocyte. These are the blasts. You saw the 34 positive blasts. They mature, and gain. They lose 34 and gain 64. That means the 34 becomes negative, 64 becomes positive. The same way, the 36 become positive as the cells matures to the mature monocyte. You can see here the pink color cells are the earliest monocytic precursor. These are intermediate monocytic precursor which correlates with promonocyte, and these are mature monocytic precursor. And these are all maturation pattern. Okay. So these are the maturation pattern as I mentioned with 14 and HLA-DR, 13 and LNB. There are additional marker which can be studied by using 300E, which is an additional marker. So you can study multiple markers with multiple pattern. But 13, LNB, HLA-DR, 14, 64, 36, these are the common markers which are used. Now, one more aspect of monocytic study is to study the compartment of monocyte. The monocyte is 14 positive but HLA-DR negative is called the classical monocyte. These are the compartments of mature monocyte compartment. So if you take mature monocytes, they can be divided into three parts: 1, 2, 3 by using 14 and 16. The part which is 14 positive is called the classical monocyte. The part of monocyte, mature monocyte, which is 14 positive and 16 negative, are called the classical monocyte. They are also functionally different. The part of monocyte which is 14 positive, strong 14, but weak CD16 positive, indicated by the brown color here, are called the intermediate monocyte. And the monocyte which are 16 positive but 14 dim to negative, called the non-classical monocyte. So we have classical monocyte, non-classical monocyte, and monocyte which are connecting them, which is in between, called the intermediate monocyte. Okay, these three compartments are there. These three compartments are used for the diagnosis of CMML. I'll show you how. So this is a maturation pattern of mature monocyte. Maturation pattern of mature monocyte. Okay, as I told you, there will be classical monocyte, intermediate monocyte, non-classical monocyte. Right. Now, normally these classical monocytes are, when you take mature monocyte, in all normal individuals, under normal conditions, these classical monocytes are usually less than 94%. If you take total monocyte, these classical monocytes are less than 94%, and the remaining 6% or more than 6% is contributed by intermediate and non-classical monocyte. Now, in CMML, that is chronic myelomonocytic leukemia, what happens? There is arrest at this stage. When I say arrest, means the cells do not differentiate from classical monocyte to intermediate and non-classical. And since there is arrest and restriction, this compartment becomes beyond the limit of 94%. And so usually they are more than 94%. So when you have a patient suspicious of monocyte, of classical CMML, that is patient with monocytosis, and you want to diagnose if this is a case of reactive monocytosis or is this a case of chronic myelomonocytic leukemia, In peripheral blood, we study the compartments of monocytes, and if that monocyte is more than 98%, classical monocyte more than 94%, then it can be considered as a CMML. It has very strong correlation with molecular data, and using based on the molecular data, they have come up with they have shown that the classical monocyte, if they are more than 94%, are considered as a CMML. Okay. Again, in case of CMML as MDS, what abnormality we see? The usual abnormality seen is the loss of HLA-DR. Here you see the normal maturation pattern, here abnormal maturation pattern. So what happened? The cell still shows maturation, but the loss of HLA-DR, so they have become outside. The expression of HLA-DR has become negative. That is aberrancy. The other common aberrancy we see is the straightening of this pattern. You can see there is homogeneous expression. There is no this pattern. This pattern is lost. They have become all single stream, or the pattern is there because of overexpression of HLA. So loss or gain, overexpression of HLA-DR. These patterns are usually seen in myeloid dysbiotic monocytic lineages. The commonly seen in MDS can be seen in other neoplasms like CMML as well as GMML. Let's go to the another question for our participating students. So I have 4 statements here. Which of the following statement is false or wrong? CD34, CD117 and CD16 are commonly used for the study maturation of monocytes. That is one statement. The other statement is 14, 36, 64 HLA-DR. These are commonly used for studying the maturation pattern of granulocyte. The third option is both, and fourth option is none. Which is the correct? Yes, that is true. So this both options, because we use 14, 36 and HLA-DR for not granulocyte but for monocyte. 34 and 117 are used for the blast, and CD16 used for granulocyte or even monocyte. So these both statements are wrong. Correct. Okay, let's go to the next. Now,
So we have some questions. Shall we take after the session?
No, you can take it now.
Okay, sir. How do we draw the normal maturation pattern if we try to make a protocol? What if we draw a bigger compartment and abnormal cells get included instead of standing out?
Okay, so so what we do is during maturation, study of maturation, if I understood the question, how do you identify the major population and then study for the maturation pattern, right?
Yes, sir.
Yeah.
I think so.
So first we can identify granulocyte using the side scatter, but sometimes even side scatter is down regulated because of the hypogranularity. Then we use the anchor marker like CD15. CD15 usually strongly expressed in the granulocyte. So using side scatter and CD15, we can identify the granulocytes. And once you identify granulocytes, that means you exclude monocyte, erythroid cell, lymphocyte from that population, and then study different maturation patterns. Same way for monocytes, also use the combination side scatter and CD33, because CD33 is strongly expressed in monocyte. And using the side scatter, because monocytes will have low side scatter and strong CD33, you identify CD33 strong and low side scatter monocyte and study different maturation patterns. Because other markers can have down regulation or aberrant expression.
Prashant, I think the person who asked the question, you had shown the normal gates in which the stem cells fall, no?
Yes.
So he was asking about how you draw the gate.
Okay, the gates are drawn based on using the normal bone marrow. So we receive bone marrow from the staging sample. So we receive either you take the bone marrow from the normal healthy control healthy samples. For example, the sample where the person who is going for the orthopedic surgery, right? You can take them, or some European Western countries, even they are volunteers which willingly go for the giving the bone marrow, or we use the normal bone marrow which is not for the purpose of submitted for the purpose of other purposes. For example, solid tumor staging or the lymphoma involvement. So in lymphoma you will have normal myeloid cells, so you take those samples and study them. And based on the at least 10 to 20 normal bone marrow, we study take the combination, and we draw those gates based on the normal maturation pattern from this normal staging bone marrows. Did I answer your question?
There is no reply, sir. So the next question is, how do we differentiate blast and stem cells by 13, 33, 117, HLA-DR and other markers? Blast and stem cells.
So blast and stem cell, you need CD38 because 38 the negative expression identifies blast. In the absence of 38, if your panel do not have 38, then sometimes HLA-DR, because HLA-DR also shows weak expression of the stem cells, also shows weak expression of HLA-DR. So you can use HLA-DR. So weak HLA-DR or weak to negative 38 expression can be used. But in the absence of these two markers, it is difficult to identify stem cells from the blast.
Okay, next question, sir. Sometimes megakaryocytic markers can be expressed on blast due to platelet binding. So how do we differentiate whether it is true or not? Also, should those events be counted in the blast events for quantification or just platelet events?
No. Okay, so there are two questions. Two part is how are you sure that this is true positive expression of 4161, that is the megakaryocytic marker and not the platelet. This is a $1 billion question. There is no right answer to that, like based on the percentage of. But what usual the flow cytometry expert or community follows is that if you have usually platelet will bind to the subset of blast, right? But if you have megakaryocytic blast, all megakaryocytic blast will be belong to the million, or majority of blast will belong to the true megakaryocyte lineage. So when you have more than 50-60% of blast showing the expression of megakaryocyte marker, then we consider it a true positive, because majority of blast is showing the expression of this one. Because platelet will not bind to all blast, but platelet will bind to subset. So when you have a blast subset of blast, let's say 20%, 20%, 30%, only those are blasts are showing expression of 4161. Then usually it is associated possibly these are the the platelet which are attached. You can also correlate with the other cell population. Let's say granulocytes or lymphocyte you take, and you see how many what are the percentage of these megakaryocytic markers are showing this expression of platelet markers. For example, 4161 positive is 30% of granulocytes. These are neutrophils, granulocytes, right? Or lymphocytes. That means those are platelets. So if the blast also shows a similar amount of expression of 4161, basically that means this is coming from the platelet binding, not true. But if majority of blasts, 70%, 80% blasts are showing 41 expression, 61 expression, and only 12 or 15, 20% are granulocytes or lymphocyte expression showing that of the expression of 4161, then you can comfortably say this is true megakaryocytic marker positive expression on the blast.
Should those events be counted in the blast events for quantification or just platelet events? This is part 2 of the same question.
So you have to consider actually all blasts when you are interpreting megakaryocytic marker. If you just consider 4161 positive, then you will see it will be the 100%, right? So you have to, the blast should be considered based on the baseline marker, like CD34, 117, HLA-DR, using those homogeneous expression of those markers.
How to keep the cutoff gate in 14 versus 16 plot?
How to use a cutoff for 14 and 16?
Yeah,
so
14.
Yeah, so that which I have shown here already. Here, so you have to use based on the expression level. So see the expression of 14 and 16. There are two different levels. One is 16 negative, 14 positive. The one where the 16 start appearing. So you can see the 16 start appearing here, right? You can also use internal control. Let's say some lymphocytes. Let's say T lymphocyte, something as an internal control to define it. Where or the internal monocyte, you will have even monocyte. You can see that majority of cluster is monocyte negative. So you can take as an internal control for the monocyte 16 positive. And here only a subset of is showing 16 positive. So there you put a cutoff and they start with 16 positive, and here you can see this 14. Now from here the 14 is going down and 16 has become a homogeneous strongly expressed. The population where the 14 is going down but 16 is strongly positive, you put a cutoff there. So 14 and 16. So where the moment the 16 start and 14 is homogeneous, that is intermediate. The moment 14 is going down and 16 is homogeneous, that's your non-classical mode.
Next question is CD15 versus CD13 pattern in promyelocytes.
CD15 and
13, CD13, 1, 3.
okay, CD15, 13 and 15 also shows maturation pattern. I have not considered. See, if you combine many markers, you will get multiple marker pattern. So for the sake of today's talk, we have not gone through the different, but the immature monocytes usually express 15 and they are 13 negative, and mature monocytes are 15 negative and 13 positive. So there is this maturation pattern. We can study more 20 more markers and study different maturation pattern, but to keep it simple and less complex, we are focusing on these markers. Okay.
If gating is done based on normal bone marrow sample, can it vary based on population type due to different genetic makeup?
You have to repeat that question.
If the gating is based on normal bone marrow sample, can it vary based on population types due to different genetic makeup?
No. So that's what I'm saying. See, these antigen expression is tightly regulated by gene expression pattern, and we know that all human beings, their gene expression is homogeneous for all different races. So it's same. But the moment you have aberrant genetic expression, either because of polymorphism or because of clonal hematopoid, clonal genetic aberrancy, like which happens like say leukemia or MDS, then this pattern changes. Okay. So but the normal healthy individuals, no matter where the person is wherever, they have the same. If you have different gene expression because of the faulty gene expression, because of either polymorphism, which is normal, for example, CD16 polymorphism is very common. So you will see negative expression of CD16 in granulocyte. That is not abnormal. That is just a result of polymorphism. Or you can have clonal hematopoiesis, either part of MDS or leukemia or CMML or JMML, any hematopoietic disease. Then also we'll say the altered expression pattern based on the level of how much the gene expression pattern is causing the alteration of protein expression. Sometimes gene expression may not result in protein expression alteration. In those samples or those patients, you may not get aberrant. So not always you will not get the gene expression pattern or altered gene expression pattern may not always result in aberrant protein expression. Okay.
Sir, one question, two more questions. In the ontogeny which was shown for monocyte normal maturation and CMML, how was that validated?
In CMML.
The actual question is how actually you have validated ontogeny study you showed for monocyte normal maturation and CMML.
So normal maturation, see, so there are two things. Once you study normal maturation from the healthy individual or staging bone marrow. So you study healthy individual or staging bone marrow for all this maturation. And because that, so deviation, then you study the typical cases of CML, well-established cases of CMML or CML, and you study what is the difference and how they are reproducible. So like there are studies which are published in CMML, chronic myelomonocytic leukemia, these compartments of classical monocyte or intermediate and non-classical monocyte, and you are studying normal people. In MDS also you are studying these aberrancies in the known case of MDS, well established, morphologically and genetically established cases as well as the normal. So you have healthy controls, we have well established controls, that is positive controls, and then you study and then this. Now there are a lot of papers which has been published for the last 20 years. There are more than 100 papers which shows what are the different abnormalities, how this maturation pattern occurs and all that. So you can always look at based on the studies we have we have defined this maturation pattern, and we have confirmed or validated all these maturation pattern in our lab using our own antibody combination or the flow cytometry panels.
So what are the genetic or proteomic study you have related to the above said validation for pattern or ontogeny studies?
Okay, so some patterns are typical of some genetic abnormality, but not all proteins. Okay, right. So for the gene expression, some genetic abnormalities, for example, let's say acute leukemia. We know acute leukemia with biallelic septa, or let's say a common example of RUNX1 T1 expression. We know that there is a typical expression of CD56 and 19 on leukemic blast, or CD56 expression on the granulocyte, which is aberrance. So that those proteins are typically shown they correlate with genotype. Okay. But not all maturation patterns will be correlating with a typical genotype. They may show alternation, but that is not a specific to the typical genotype. Some are typical. For example, in CMML, you can have any mutation, right, which is RUNX1 mutation or other mutation which is associated with myeloid abnormalities. But you always get this compartment in monocyte. So the monocyte compartment is reproducible, but it may not be correlated with a typical and or a specific genetic mutation. Some are associated with genetic mutation, some are not associated with genetic.
That's all, sir.
I think if I can, I'm guessing. I think the person who asked the question wanted to know like what we are saying, that this is classical, intermediate, non-classical. What is our, so many of what we are showing is what is already published by other groups, and there is a lot of intergroup agreement on this. So that is one way of cross validation. As per se, we have not done detailed say sorting and analysis to show that this is this particular, that is not done by us, but there are other groups who have done that and showed that these patterns are related to. Regarding the CMML, yeah, these patterns are very well described in CMML in large series studies, and they are now used in disease classification also. So these pattern more or less are good to help us diagnosis. But if you are saying are these patterns specific for CMML, they are not. They can be seen in other clonal conditions, but basically they indicate, these pattern changes may more or less indicate, in not alone but in consonance with other findings, are indicative of diagnostic definition.
Yeah. So as Dr. Mani has said already, so there the people have even done a functional assays also. So like non-classical monocytes, they have different function. Classical monocyte different function. They have done culture studies, so they differentiate in a different way. So non-classical monocyte behave like a macrophages, or type 2 M2 type of macrophages. Monocyte behave like M1 type of macrophages based on the function also. So based on the function and antigen expression, they are divided. This is well established categorization. Last 30 years it has been studied in depth, but what we are the last 5 or 10 years, the people have studied them for the defining and classification of diseases like this. Okay, so like CMML, they have shown that if you take 100 cases of CML, more than 96-97% of cases will have this typical restriction of classical monocyte in more than 94% of. There is a group from the French, there is a group from the US, and we have also validated all these findings in our lab. Okay, let's go to the eosinophil. Now, eosinophil maturation is not well studied. There is 1 or 2 studies only there, and we have studied in our lab. So I am showing you the data from our lab. Now we know that these are the eosinophils. The eosinophils, we need to study a specific markers. I think I will go just run through it because we'll have time limitation. and it's not very well needed or used for the clinical application, but this is just for the sake of for the purpose of students to know that it can be studied like that. So we use Siglec 8. Siglec 8 is a specific marker for eosinophil. It is strongly expressed for the eosinophil, and we use a combination of Siglec 8 and CD244 to study eosinophils. The eosinophils can be they are typically HLA-DR negative and Siglec 8 positive, and they are 81 positive. Okay. So based on that, based on that we can combine this marker like Siglec 8 and CD193 and IgE. We know that they express this one. So using CD81, 244, and Siglec 8, we can identify the eosinophil. And in eosinophil, the early eosinophil are usually 193 negative. This is CCR3, and functionally active eosinophil, that is later stage of eosinophil, as CD193 positive. Okay, and the terminal eosinophils, highly activated eosinophil, also express IgE. So if you look at the pattern, they go like this. Okay, like this. So using this combination, you can still even study. We don't know the clinical application of this study, but there are studies which can be used. These flow cytometry markers can be used to differentiate between idiopathic hypereosinophilia, non-reactive eosinophilia. Okay, let's go to this is the question on the eosinophil only. Which one of the following marker is specific for eosinophil? 244, 81, Siglec 93, 190. Okay, so I'm happy that the students still not sleeping and still they are attentive. So it's a Siglec 8. Okay, now coming to the erythroid maturation. Now we know the erythroid maturation, we have pronormoblasts, then intermediate normoblasts and late normoblasts. Even though those stages can be further looked morphologically can be subdivided. Now they all divide from the blast, which are megakaryocytic erythroid progenitors. So these are usually 34 positive and 117 positive. The earliest pronormoblast, which immediately differentiate from the CD34 or the stem cell, is megakaryocyte erythroid precursor, and those can be studied by using the combination of 117, CD105, 43, 71, and 235A. Okay, so if you take this combination, the earliest precursor are usually positive for CD117 and negative for CD105. Okay. The next immediate state of pronormoblast, that is typical pronormoblast, are positive for 105 as well as CD117, but negative for CD34. So CD117 positive, 34 negative, and 105 positive are the typical pronormoblast. They show strong expression of 34 and weak expression but intermediate expression of CD71. They are typical negative for CD235A, which is glycophorin A. A typical pronormoblast is CD117 positive, 105A positive, 71 intermediate positive, and 235A negative. The next stage is the next stage of pronormoblast, that is mature the differentiated pronormoblast. Again, we are talking still pronormoblast because pronormoblast can be differentiated earliest and the typical pronormoblast and the intermediate pronormoblast. These pronormoblast shows strong expression of 105A. There is strong expression of 71, and at this stage, the late part of pronormoblast also starts showing the expression of 235A. Next stage is the intermediate normoblast, and this intermediate normoblast is showing the loss of 117. You can see there is loss of 117. There is still expression of 105, which is weak, but still it is there. There is some loss of CD43, so it is the intermediate, and a strong expression of 235A. Okay. So using the combination of this, we can differentiate the earliest precursor, the typical precursor, and the late pronormoblast. Okay. So these colors identify the different part of pronormoblast. and intermediate normoblast. So you can see this is intermediate erythroid cell, which shows weak or loss of 105A. There is 43 weak expression, 71 strong, and 235 nicely positive. The next stage, that is late normoblast, are typically correlate with the cluster which is CD117 negative and 105 negative. It has strong expression of 71, loss of 43, and strong expression of 235A. So 235 strongly positive, 71 strongly positive, negative 117, 105, loss of 43. Loss of 43. Okay. So by using these four markers, you can typically study the different stages of normoblast maturation. We have pronormoblast, intermediate pronormoblast, earliest pronormoblast, intermediate normoblast, and late normoblast. This is the typical maturation pattern of normoblast maturation or erythroid precursor maturation. What if we use additional marker like series 36 and 45 in addition to 235A and 105? So I'm just adding 36, 45 to these markers. So how these patterns look? This pattern look like this. So 36, that's why 36, 71, 235A and 105 is typically used for the maturation pattern of erythroid series. Now this is abnormal maturation pattern which occurs usually in erythroid MDS. So you can see the normal maturation pattern here. You can see we typically these cells have become lost, shows the loss of CD71 expression or even loss of 105 expression. You can see the normally it should go like this, but there is loss of 71 expression in early precursor. There is loss of and there is increased population here, loss of 71. The same way increased population now in normal maturity, in normal bone marrow we have usually 10 to 15% of early precursor, that is pronormoblast, and then we have majority of erythroid population is intermediate late normal. But if in MDS, because it is a dysbiotic erythropoiesis, ineffective erythropoiesis, usually a latter component is destroyed and it's seen less, and we have more early precursor. So in that means that the pronormoblast and intermediate normoblast population is high. So when you have higher population of CD105 positive population, it also indicates ineffective or dysbiotic erythropoiesis. So here you can see this in this example there is 84. In this example, there is 69%. So you have that. And the other common example is loss of CD71. So loss of CD36 expression, loss of 71 is the commonest aberrancy in erythroid maturation in these erythropoiesis, as well as increased proportion of pronormoblast also is a common feature of these erythropoiesis. Okay. So questions for our students. The following markers are most useful to evaluate the 13, right, C. So it is a C because we know that 13, 11B and 16 is used for 13. Okay, I will ask additional question. 13 and 11B, 16 for, sorry? Option A used for what?
Monocyte and granulocyte.
Right. This option A used for granulocyte, option B is for monocyte, and option C is for erythroids. Okay, that's quickly basophils and dendritic cells. Now you know the dendritic cell, there are multiple subtypes. You have primary plasmacytoid dendritic cells, and then you have myeloid dendritic cells. This is called as a typical dendritic cell. These are plasmacytoid dendritic cells. And if you look at more deeply, you can have 6, 7 more dendritic cells. Now, dendritic cells also mature from the myeloid stem cell and basophils. So they show typical match. So myeloid stem cell, by using combination of 123 and HLA-DR, we can identify two types of cells. The cells which are 123 strong But HLA-DR negative, these are basophils. The cells which are 123 strong, but HLA-DR is also strong, these are plasmacytoid dendritic cells. And myeloid dendrocyte cells are usually false here. They are 123 weak and HLA-DR positive, but they are typically 11C positive. Okay, the same way, if you take combined CD203C and 123, the cells which are 123 and 203 positive include basophils, and the cells which are 203C negative but 123 positive and HLA-DR positive are plasmacyte dendritic cells. Here, this is peripheral blood. So you can see in peripheral blood, if we have 11C and 123 positive, we get 123 positive, and out of 123 positive cells, the cells which are HLA-DR negative are basophils. The cells which are HLA-DR positive are plasmacyte dendritic. The cells, these cells are, you can see the 203C positive basophils, and basophils also shows expression of 13 and 11B. As I mentioned earlier, 13 and 11B is typically positive in basophils. They are moderate and homogeneously positive. 123 positive, DR negative, 203 positive, 11B positive, 13 positive, and 33 positive. These are the basophil markers. The cells which are HLA-DR positive and 123 positive are PDC. Now the cells which are 11C positive but 123 weak positive, these are myeloid dendritic cell, MDC, or typical dendritic. Okay, just to show you, this is a case of CML where, in CML case we have increased number of basophils. Now these basophils usually shows the down regulation of 123 in CML, because CML is also clonal hematopoiesis. It will show basophil but not normal one level of 123. Down regulation of 123 is typically seen, and you can see they are confirmed by using 203 and 193, and they are also HLA-DR negative. This is case 1 and this is case 2. So you can see there when the loss, the down regulation of 123 can be seen. Then PDC, as I mentioned, this the basophils, they also shows the weak no expression of dendrite. This is another dendritic cell marker like CD304 can also be studied. This basophils also shows expression of CD38. They shows relatively brighter CD45, like close to the lymphocyte. Now coming to the subset of PDCs, PDC can be further subdivided using the CD4 and 7. So you can see the PDC, they shows expression of 303, 304, and they can also have the antigen, the lymphocyte antigen expression like CD7, 4, 56, 5. These are normal PDC. This is MDC, as I mentioned. You can see the MDC are 123 positive, 11C positive. They are typically HLA-DR positive, and 11C is the marker which is useful to differentiate between PDC and MDC. And MDC can be again further subdivided by using CD1C and 141. So there you can have 3 subtypes. One which is both positive, one is both negative, one is only 1C positive subtype. Now mast cell, as I mentioned, mast cell shows overexpression of 117 and down regulation of HLA-DR. So you can see the stem cell typically shows 117 expression and loss of HLA-DR. So these are your mast cells. They also express 33 nicely and 117 strong. So 117 usually very strong in stem cell. Now question for our student: which of the following markers are commonly used to study plasmacytoid dendritic cells? Option A, 244 84 neglected. Option B, 123 303 304. Option 3, 43 235A 36, and option D, 123 11B 13.
123, 303 and 304.
Yes. So the option B is the correct answer. A is for eosinophil, that is 244 81 neglected. B, C is 43 235 and 36 for erythroid cell, and 123 11B and 13 can be used for basophils. Okay, so here with I think the maturation pattern I have finished. Now I have typical 3 cases. So if we have time, I can go through it. So I have to open other presentation. Do we have time?
Yes, sir.
Moderator?
Yes. Yes, sir.
Shall we?
Yes, sir. You have time. Yes, sir. We can see.
Okay, it is already 9 o'clock. Okay.
Yes.
Okay, so I'll show you the 3 typical cases and quickly. Okay.
Yes, sir.
So this is case 1. Now we had history of 58-year male, old male patient, and I want the participant or student participant to give their opinion based on the just what we have seen and gone through. Now this is a patient which is 50-year patient evaluated for on and off fever for 8 months. Okay, so and there is also skin rash, history of skin rash for last 2 months. Patient also known case of diabetes and hypertension. Now patient was evaluated at a peripheral center and found that there is a patient has anemia. The TLC is increased, that count was increased. The count was 15,500, in which there are approximately 8 to 9% were monocytes, and absolute count of monocyte is close to 2,000. Platelet counts normal, that is 4.2 lakh. Okay, this is your CBC and this is the history. Now this is CBC in counts. You can see this is the CBC of patient. There were approximately 9%, as I mentioned, where the monocyte absolute count you can see there increased more than 1% and one. This is actually a different type 1. This was at the time of presentation. This is little later on. Okay, so the patient has monocytosis with increased count and there was anemia. This is the peripheral blood picture. You can see the peripheral picture is not the cells. You can see there are some monocytes with some vacuoles is there. This is another picture. There are some neutrophils also. This is true case. So you can see there is even some vacuoles in granulocytes also. You can see possibly some hypogranulation is there. One or occasional immature cell is also you can see in the circulation. This looks like a myelocyte. These are the monocytes. You can see the increased monocytes with vacuoles. So what we have done flow. In flow cytometry, because this patient has a typical high monocytosis and the patient has a long history. So for the patient of monocytosis, we suspect and we wanted to exclude the possibility of chronic myelomonocytic leukemia. So we have done a tube. This is actually a 16 color tube. That means we have added 16 antibodies single tube. Okay, and in this 16 color tube, we have included both myeloid marker, blast, the study you can see the monocyte, the markers of blast like LL34-117. We have markers of myeloid 13, then 11B 16. We have markers of monocyte at 64, 14, 64 HLA-DR. We have markers which identify granulocyte, that is CD24. We have markers to identify stem cell, that is CD38 and 34. We have marker for aberrant expression of CD56. So this is the marker. All markers are there in single tube. Now, not many lab in clinical lab. Usually, clinical labs have 8 to 10 color or 12 color assay. We in our lab we have 16 color assay. So we use 16 color assay. Now we have looked at different markers. So this is called as a gating. Now someone who is asking gating. So if you want to study only granulocyte, we put a gate on the granulocyte. If you want to study lymphocyte, based on the low side scatter and 45, you identify only lymphocyte. Based on the high side scatter, because you can see the side scatter is very high. These are granulocyte. The side scatter is weak, but high CD45, these are monocytes. And the cells which are CD45 weak and low side scatter, this is a progenitor gate. or where we will get blasts. So you can see in peripheral blood, we have lymphocyte, monocyte, granulocytes, and there are some blasts also there. Right. Now, instead of using 14, the CD24 is typically expressed in granulocytes and lymphocytes. So we use CD24 to identify granulocytes and to separate them from the monocytes, because monocytes are typically CD24 negative. Okay. So we get CD24 here, and we have for the granulocytes, and the rest of the cells are here. So based on CD45 site scatter, we identified 4 populations: granulocytes, monocyte, lymphocyte, and blast or precursor cells. Now we focus on the granulocyte for maturation pattern. This is not bone marrow, but we have seen peripheral blood, we have some precursor cells are already there. So here you can see predominantly there are neutrophils, but still we have some immature cells which are 11B negative and 13 positive, or which are 13 negative and 16 negative, right? We can see there, these are there, because in morphology also we had. So what do you think? Is this a normal, or is there any abnormality? Any student or any volunteer who would like to reply that? Okay. So if you So if you look at this plot, 11B and 13, it looks predominantly normal. We do not show any abnormality. Predominantly, we have neutrophils and there are few immature cells. But if you look at 13 and 11B, usually you get nice tight compartment. But you see there are some cells which are going here, up till here. There are some cells which shows 13 overexpression, and there are some cells here. So that means a subset of granulocytes shows some disperses there. They are not tightly clustered like we have seen in maturation pattern. And here also, if you look at 13 and 16, usually it goes like this. It goes usually it goes like this, okay, but clearly instead of that it is going like this. So there is this angle has been shifted to this. So that means there is some overexpression of 13. Because of that, this maturation pattern is increased, and this part is showing some overexpression of 13, usually, because normally it goes like this. The tight expression is there, which is like this, right? But this part is showing some aberrancy, and this part is some aberrancy. So there is some disperses, some degree of disperses there in this part of the granulocyte maturation. Then let's go to the monocyte. Now in monocytic compartment, as I mentioned, what we have done is we excluded this part, this granulocyte, and then we gated this part of monocyte broadly using 11B and 14. So this part is gated, and using this gating part, then we identified our monocyte by using combination of 33 and 64, because that broad gate, monocytic gate, we know that 13 is nicely, 33 is usually strongly positive, and 64 is variably positive in monocyte. And then out of them, if there are few granulocytes are there, we have excluded this part. So we have this part which is clear, clean monocytes. Okay. Using this, then we study the compartment. So if we look at this compartment, we have the 14 positive, and this here there we have the gating pattern. So we have some part which is 14 positive and 16 negative. Here is the other part which is 16 positive and 14 positive, and this is the third part. So classically, you can look at majority of monocyte are 99% are monocyte which are classical monocyte. You will see there is some spread is there, but that is because of the 14 strong expression. This is not true expression. And here starts your 16 positive. The same way, the other marker is which we use is for the non-classical monocyte is SLAN. Okay, this SLAN is a typical marker. Normally, it is expressed up to 1.7%. 1.7% of total monocyte or above 1.7% of total monocytes is SLAN positive non-classical monocyte. I'll repeat this again. SLAN positive non-classical monocyte normally is more than 1.7%. Now, how this 1.7% come? So this is the multiple studies, the study by French group, a study by MD Anderson group. They have shown that the SLAN more than 1.7% is shown is expressed in more than 1.7%, as well as in the non-classical monocyte. If you have less than 1.7% of cells showing SLAN positive monocytes, then again it becomes a case of classical monocyte. Okay, it becomes a CMML. So here in this case, you can see hardly any SLAN positive, 16 positive monocytes, less than 0.03%. That means clearly absence of SLAN positive, which confirms the diagnosis of absence, confirms the absence of non-classical monocyte based on 16 as well as 16 14 as well as your SLAN expression. Okay, so this is the aberrancy, that is absence of non-classical monocyte, indicating restricted classical monocyte pattern. Now, this was peripheral. We received bone marrow. You can see the bone marrow aspirate. The bone marrow aspirate is hypercellular. There is some dysbiosis in megakaryocyte. Again, you look at some the granulocyte. You can see the different granulocytes. There you can see the some dysbiosis there in the erythroid series. Myeloid maturation shows, I think we have some degree of hypogranularity. Is there some degree of dysbiosis in granulocyte? Here you can see, you will appreciate some degree of granulocytic dysbiosis. Here also some hypogranularity is there. Here some degree of hypogranularity is there. You can see the granules is almost absent in this granulocytic population. There is dysbiotic maturation, the segmentation of these cells. This is another picture. This is another picture. There are a few blasts are there. You can see this. This is another blast. You can see here. This is another blast. So different pictures. So even in bone marrow also we have studied the same thing. And then we look at here. So bone marrow classically represent, I showed there were hypogranular cells. So you can see the side scatter is not nicely high. You can see there are the subset of cells which are almost touching the monocyte level. That means there is a loss of side scatter, which indicates hypogranularity. Okay, which we have seen in even the morphology. And then we see there was some blast. So when we look at the blast, this is normal. You can see this is normal. So normal is lost. So you can say normally there is a tapering of this stem cell which is there, which is lost. You can see there is a clustering of this CD38 negative blast, which is clearly abnormal. And also this normal maturation pattern is lost. You can see the normal maturation pattern. There are 13 positive blasts, but 33, 38 is negative in this population, which is usually should not be the part, right? So 38 negative, 33 to 30 positive cells should not be there. Again, this compartment should be small. This is clustered and increased compartment. So there is clearly the abnormal blasts were there. Another picture, another combination. Normal maturation pattern. You see, this is the normal maturation pattern. Here you can see this. This should be normal maturation pattern, which is like this. But this is lost because there is a clustering here. There is clustering here. So normally you should normal maturation pattern going to be like this, but here you can see there is a clear clustering. Here there is a clear clustering because normally it should go like this, but here clear clustering is there. Now coming to the granulocytes. Granulocytes, you can see this is the normal maturation pattern. As I mentioned, there are two types of cells. The one is showing some normal maturation pattern, and some are going directly like this. So there is a maturation dysbiosis there. 117 is another marker we use. Loss of 117 is also used as an aberrancy, and overexpression of 117. I will not discuss 117 because this will go into the true detail there. Even monocyte, even in the bone marrow also you can see Only classical monocytes were there. The non-classical monocytes are typically absent in this part. Okay. Normally, you will should see this type of pattern, non-classical monocyte there, but here and the maturation pattern here you can see the overexpression of 13 is there, and some degree of 15 is there, which is also in normally it should go like this. Normally it goes like this. The precursors are 15 positive, and the mature are 15 negative, 13 positive. Normally it goes like this. Okay, so this was the monocytic feature. So the final diagnosis, because there were dispoids in granulocytic lineage, monocyte lineage, monocytosis, abnormal blast. So this was a case of, and but the blast percentage were 2% only. So this was a case of that we give the diagnosis of CMML with type 1 CMML. Okay, with the dispoids in multiple lineages and restricted or increased compartment of monocytic lineage. Yeah, you can see the classical monocyte were 98%. Okay, on cytogenetics, it was negative for typical translocation. And on molecular, we had molecular mutation in the 3 here. You can see that there was mutation in next gen sequencing. So these were the the genes in which found the mutation. Okay, so this is how it confirms the diagnosis of CMML. Now another case. Any question regarding the earlier case? Okay.
Sir, one question is, can vexus be considered for this case, sir?
Can
Vexus be considered for this case, sir?
vexus usually present with cytopenia. Then the blast also shows vacuoles. The monocyte normally also has vacuoles, right? So monocytes usually have vacuoles.
For vexus, the vacuole should be there in almost all of the cells, yeah, including immature. And second thing is, in this, I think the vexus mutation is not there.
And other is also, we are looking at the bone marrow picture did not show vacuolation. Only peripheral blood monocyte shows vacuolation. So bone marrow, if you look at bone marrow picture, there was no vacuolation. In vexus, you will get vacuoles in bone marrow also, bone marrow cells also, and all lineages, all stages also, even some blasts also. Okay, next case. A 76-year woman with progressive chest tightness, that means anemia. The patient had thrombocytosis. Okay, and but severe anemia. Platelet count was and the hemoglobin was 3.6. And even the TLC was low. So bicytopenia is there. This is a picture of bone marrow. You can see. So in bone marrow, you can see there is some segmentation related abnormality is there, but clearly hypogranulation is there. You can see you don't see the granules. There is hypogranulation is there. The abnormal dysbiotic segmentation is there. Even the erythroid cell shows dysbiosis at this stage. Hemoglobinization is there, but still, so nuclear cytoplasmic delay is there. Yeah, there is some dysbiosis in the erythroid series is there. Hypogranulation of myeloid series. Here another dysbiotic segmentation of granulocyte, as well as hypogranulation is there. And if you take a erythroid series was increased. You can see the erythroid series is increased. So erythroid hyperplasia is there, and dyserythropoiesis is there. Multiple places dyserythropoiesis is there. Okay, and granulocyte shows hypogranulation. You can see here hypogranulation. The closer view of erythroid series, dysbiosis, hypogranulation, dysbiosis. Another picture. And there's a dysmegakeropiesis also. You can see here. Dysmegakeropiesis is there. They are hypolobated. Their megakerocytes are there. Here, then dysbiotic megakerocyte. Here you can see. Okay, so that is morphological despite another morphological micro-makes kind of situation, hypolobated megakaryocyte. So there are multiple disperses there. So we have done, in addition to myeloid lineage, so now we have what here we have looked at the both because we want to study myeloid as well as erythroid. So we have two 16 color tubes. In myeloid, we have granulocytic marker, monocytic marker as well as blast marker, and if we have erythroid, the erythroid markers. Okay, so again we start with the identifying viable cells. Here you can see the predominantly granulocytes show low side scatter because there is a drop of side scatter. Normally it should be here, but here majority are here, so which indicates that hypogranulation is there. So hypogranulation is also confirmed by flow cytometry. And then again sites 45 side scatter, you have granulocyte, monocyte, and blast precursor. You can see the blasts are not increased, but just clearly there. We identify granulocyte by using CD15 and LMB. You can see CD15 positive are the granulocyte and CD15 negative, and this one are the eosinophils. Then this is a complex plot to identify if there were hematogones because all myeloid markers negative, 34 positive cells. Usually we identify hematogones were negative, and you can look at the maturation pattern. So normal maturation pattern here it looks like more or less normal, but here it is abnormal. You can see there are segmentation, clustering is there, and normal maturation pattern should go like this, which instead of that it is going like this. So there is clustering. Normally it showed like this, but here you can see that it is going like this, right? So there is some dispersing maturation pattern is there as compared to the normal. You can see the normal plots are shown here. Then so there was dysbiotic granulocyte maturation pattern. Even the blast shows aberrancy. You can see the here there is increase in the population of stem cell, loss of 13 in CD38 positive population. There is down regulation of 13. Then normally it should go like this, but it is going like this. So there is some aberrant maturation pattern. See, normally like go like this, but here it is going like this. So there is diagonally abnormal. There is clustering of blast is there. There is loss of CD33 is there. Sorry, I have to take this call from my dad, and he's calling frequently, so I'll just. Hello. What? So that was my dad. He had wanted to talk something, and he was calling frequently, so I had to take this. Okay, so okay, so these are the abnormalities we have seen in the blast. So blasts were abnormal. Then coming to the erythroid cell, we use typical getting pattern for erythroid cell. We identify cells by using 49D and 305 because 49D is homogeneously expressed in immature and mature erythroid cell. The other markers like 71 shows down regulation in this species, 36 can show down regulation in this species, but 49D do not show any aberrancy. So 49D is the best marker to identify the erythroid cells. So we identify erythroid cell and then use the combination of this. Combination of this, so you can see in this case the precursor, because there is ineffective erythropoiesis. You can see the normally the precursor, that is promyeloblast 117105 positive prono, usually up to 10%. Maybe in reactive condition it can go up to 15%, but they see more than that. So usually the cutoff studied by Leukemoid et al., that is from the Seattle group, they have shown that 9% and above, usually the precursor cell is less than 9%. we consider up to 15%, but more than that is also indicates there is restricted maturation or ineffective erythropoiesis, because the latter component is not there. That means the latter component is destroyed. So that is also. So in this case, you can see the 72% cells were precursor, which is clearly abnormal in this population. The other way to look at the loss of 71, in this case, there was no loss of 71, but loss of 71 in 235A positive population. If it is more than 5% of erythroid cells, shows loss of 71 is also indicates the aberrancy, that is abnormal expression or dyspoiesis. So loss of 71 in more than 5% of terminal erythroid cells, that is 235A positive erythroid cells, is also considered aberrancy. Okay, dyspoiesis. So here it was not there, but here what was the abnormality in this case is the risk increase in the pronormoblast. So in this case, we have given the marrow, and that is we have given the diagnosis of MDS with low blast, and we have advised 5q deletion. And you can see in this patient, we had 5q deletion in 95% cases. 95% cells. Okay, so that was case of MDS. This is another case. Okay. There are 4 cases. Okay, this is another case, again 66-year female patient, required multiple transfusion because of anemia. You can see the hemoglobin was very low, platelet was so pancytopenia was there. This is hypercellular marrow. You can see the marrow was hypercellular, predominantly erythroid cells. So there increased erythroid cells, so erythroid hyperplasia was there. And you can appreciate there is dyserythropoiesis. You can see the morphological picture is little hazy, dyserythropoiesis. You can see even the dysbiotic megakaryocytes are also there. You can see the hypolopated megakaryocytes are there. There is another picture. Dyserythropoiesis is there predominantly. There's some dyspoiesis in granulocyte. You can see the dyspoiesis in granulocyte, dyspoiesis in granulocyte. Okay. Here you can see the dyspoiesis. Again, another picture of dyspoiesis. So flow was done. Again, you can see the side scatter was the reduce of the granulocytes, and you can see in this the percentage of blast is more as compared to the earlier. Okay, so it looks like the possibly the blast percent is more, and we identified again the granulocyte by using 15 and blast using 34. There were no hematocones, and you can see the maturation pattern is completely lost. 1311B, 1316 complete. There is no maturation pattern at all, right? So because there is severe dyspoiesis in the granulocyte, but the flow on morphology there will be few granulocytes, and even the monocytic dyspoiesis there. You can see the monocytes shows the loss of HLA-DR. Normally, you can see the normal maturation pattern go like this. Normally, it goes like this, right? Like this. But here, if you see, if you put the gate like this, right, there is loss of HLA-DR in this subset. Okay, there is also the pattern here. Normally, it should go like this, but here the some cells are going like this, but the some cells are going like this directly, right? So which also indicate partial dyspoiesis. Blast also shows aberrancy. You can see the stem cell component is increased here, right? The compartment increase. Then there is overexpression of 13, homogeneous expression of 13, right? There is loss of 45 in this part. So normally it should go like this, but here clearly there is some down regulation of 45 is there. So there are aberrancy in abnormal blast, right? Normal maturation should go like this, but here here it is going like up, straightening of this. The pattern is lost, right? Then again here the normal should go like this, but here complete the clustering is there. So there is and down regulation of 38 is there. So there are aberrancies, multiple aberrancies are there. Coming to the erythroid cell, you get erythroid cell using 49D, and you can see in 49D again there is a clustering. You can see the instead of 15%, there it has become 26%. So that means ineffective erythropoiesis is there. So again, and the blasts were increased. The blasts were, I think, 7% of blasts were there. No, sorry, on morphology, on flow, there 14% blasts were there. So it was, the diagnosis was given MDS with increased blast, and on cytogenetics we have 5q and 7q deletion with trisomy 8, and also on cytogenetic abnormality. So that means it confirmed the diagnosis of MDS. Okay, there were also TP53 mutation was also there on NGS. So multiple genetic abnormalities were there. Now coming to the case 4, 1 year child. So almost infant, presented with swelling in abdomen, so possibly splenomegaly, and hepatosplenomegaly is there, and hyperleukocytosis, high counts. Okay, so probably for 60,000-80,000, something like that. Let's see what was the count. There is WBC in this. Damn it. And TLC is here, 76,000. Right? Hemoglobin is low after transfusion. Possibly there is monocytosis also there. You can see the monocytosis is there. Right. So we have monocytosis, high WBC count. Right. Shift to the left. So this is the picture. Bone marrow aspirate, hypercellular as we expect. You know. Here shows the normal maturation pattern. Granulocytes are there. Some megakaryocytic clustering can be seen here with. So flow was done. So I do not have peripheral blood picture on this patient, but in bone marrow, there are some cells, some monocytes are there. Here you can see there's some monocytes. Here. Picture is not very clear, I think. There some monocytes are there. Okay, so monocytosis was there. So bone marrow was done, flow was done. Now flow, you can see the granulocytic maturation. There's some maturation there, but there's some clustering is there, right? Some dispersion is there. Instead of going like this, it's going like this. So some degree of dispersion is there. Here it looks like normal maturation, but this is not normal because the gap between the cells is there. Some 16 down regulation is there, and clearly 11B over 1 expression is there. Some dispersion is there. Monocyte shows dispersion. Normally it should go like this, but here it is straight, right? Normally with 11C and 14 it should go like this, but here it is going like this. So the dispersion is there. Even the 15 is lost, and 11B 13 which should go like this is becoming straight. Normally it go like this, but it has become dispersed. So monocytic dispersion was also there. Now coming to the blast, you can see that there is blast. Surprisingly, the hematogones is not there. Being in the infant, we should see some hematogones, 34 positive, 19 positive. So absence of hematogones was there. Okay. And when we look at the blast, now we divided the blast into 2 compartments. One is stem cell compartment, which is 38 dim, blue color highlighted by tubular stem cell, and the one is mature blast. Okay, so if you look at stem cell, the stem cell is showing aberrant expression of 11B. Normally, blast do not express 11B. There is overexpression of CD7, so aberrant express CD7. There is overexpression of CD25. So aberrant expression of 11B stem cell, aberrant expression of 25 11B, and homogeneous expression of overexpressed 7 indicates abnormal stem cell, in this case, abnormal blast. So, and there was disperses in monocytes as well as granulocyte. So we're looking at the morphology and everything, the blast percentage and everything. We have given the diagnosis of, and also the JMML, the diagnosis of JMML was given. Here you can see the diagnosis of juvenile monocytic leukemia was given. And on cytogenetics was negative, and for molecular you can see the PTPN11 mutation in addition to the additional mutation was there. So such the diagnosis of some. So to highlight that even the JMML showed abnormal dispersions in both blast as well as granulocyte and monocytic component. So diagnosis final. So I think herewith I'll stop. I have shown you 4 cases, CMML cases, 2 cases of MDS and 1 case of JMML, and we have gone through. So if there is any remaining question, I'll be happy to answer.
2 questions, sir. How do you differentiate between erythroid hyperplasia and erythroid leukemia by flow?
Okay.
And how do we diagnose megakaryoblast leukemia by flow? Only those 2 questions.
Okay. So the first question, how to differentiate between erythroid leukemia and erythroid. So erythroid leukemia, if you look at in erythroid hyperplasia, usually you will have all maturation of cells. You have hyperplasia, you have pronormoblast, normoblasts, and this. In erythroid leukemia, usually more than 80% cells are erythroid cells, and out of them, more than 30% are pronoblastic stage. So if you have that category, then you have to consider the erythroid leukemia. And by flow cytometry, also those all blasts will express when 34 positive, 117 positive blast will express 105, which is erythroid marker. So by flow cytometry, you look at the overexpression of 71 and 105 expression. And by morphology, more than 80% of total nucleated cells from the bone marrow are erythroid cells, and more than 30% of them are pronormal. And the second question is megakaryoblast leukemia. So if you take blast, the blast shows typical expression of 34, 117, sometimes HLA-DR negative, and you have 13, 33, 1 expression. But then majority of blasts will show megakaryocytic marker like CD36, CD42, 41, 61. These are megakaryocytic marker. Now you have to suspect, you have to have high degree of suspicion of megakaryocytic leukemia. Either you have age, so generally, infants have megakaryocytic leukemia. The second is the blast typically shows megakaryoblast, multinucleated blast. You will say like a dark erythroid cytoplasmic, the dark blue cytoplasm, and multinucleated blast will be there. The 2 or 3 combination of, you have some scattered. There will be cytoplasmic blebs in megakaryocytic blast. So if you see the blast with blebbing, multinucleated blast, especially binucleated blast, then and typical age, then you have to have high degree of suspicion of megakaryoblast leukemia, and then you add megakaryocytic marker. In addition to that, this blast typically shows expression of aberrant expression of C1 and CD4. So C1, CD4 is there, then you suspect megakaryoblast leukemia, and then you add megakaryocytic marker to confirm. So if you have more than 2 megakaryocytic lineage marker, either 34, 36, 41, 61, 42B, out of these 4 markers, the 2 markers are there. Then you confirm megakaryocytic lineage marker along with the morphological features.
That's all, sir. It was a very excellent information loaded session. Thank you, sir.
Okay, any comment from Dr. Mani? If you want to add anything, then we can.
Mani sir has left, sir.
Okay.
Mani sir is not there. Yeah.
Okay, so then we can conclude today's talk. I think we had many questions during the talk, and hopefully I've gone through. So I hope that the postgraduate students and other people who are not exposed to flow cytometry will have an interest in flow cytometry now, because looking at its application, there is a wide variety of applications in hematolymphoid neoplasm for the diagnosis of not only leukemia, but at different myeloproliferative as well as the MDS cases. And you can study, you can have some projects or thesis projects also if you have flow cytometer. And if you are interested, you should do some workshops and then appear for hematopathology fellowships, where you will be trained in these techniques. I think then we can stop. Shall we?